and what if fails, what's going to happen next. Success of non-surgical retreatment, overall, the outcome is similar to primary first root canal treatment. Primary, sometimes they confuse it with primary teeth, so hence the word first time root canal treatment. RCT outcome resides on the ability to access, negotiate the root system to the residual apical infection. It's a diplomatic way to say trying to improve the previous root canal treatment. Now moving on, sorry, sound is okay, yes? Moving on to the indications for apical surgery. Periapical disease in teeth where non-surgical retreatment may compromise the retention of the tooth. So if you're not sure if it's heavily restored tooth, for example, with post, bridge, for example, or a crown, you don't want to remove all of that and then you're not sure about the restorability. So may you give it a go with an apical surgery. That's one indication. Iatrogenic errors or developmental anomalies, ideally, for example, a fractured instrument in the apical third. Periapical disease in teeth where non-surgical retreatment has failed. To confirm a diagnosis, root fracture, perforation, or resorption. That's in terms of exploratory, the exploratory nature of the apical surgery. I don't, for example, personally, I don't never say I'm going to do an apical surgery for the patient, or I'll just clean the tip of the root surgically. I say I'll open a flap, see what's going on, and if everything is fine, we'll just clean the infection. Maybe there is something else we don't expect, regardless of your investigations that you've done in the previous, whether you have a CBCT, good x-rays, and so on. You never know what's going to face. So it also, if you are doubting a perforation or a fracture, that's an indication for apical surgery. Obstructed canals, that's a very common cause for apical surgery, although it's not related to our topic today. A biopsy, if you are suspecting some kind of a pathological disease. So prior to considering apical surgery, the root canal system should be cleaned, shaped, sealed prior to apical surgery. Oh, that's should be. So sometimes it cannot be, obviously. But always consider retreatment, non-surgical retreatment before an apical surgery. Non-surgical root canal retreatment must be considered before apical surgery. I just said that. So how successful is root canal or apical surgery? It's in general, as a treatment, it's highly successful if it's done well with the modern concept of apical surgery, although it's not the topic of today. But these studies based on what they call, for example, endodontic microsurgery. So using a microscope, using micro instruments, biocompatible material as a root end filling or as a retro filling, and so on. So now I'm just gonna go through one case today. I'll conclude my presentation after this case, where it has it all. This case has a root canal treatment, root canal retreatment, and a surgery. So the patient presented, this is the OPG for the presentation of the patient first time. She has, let me sure, is that mouse working? Yes. So she has pain from this tooth. She had obviously had a lot of root canal treatment done in the past. She is not believing in whatever we do as dentists and especially as endodontists. She is on my chair only because she has a lot of pain, a swelling related to the central incisor, the left central incisor. She had a pulpectomy done that is not really resolved her symptoms, and she is presenting desperate for any treatment. So we did our intraoral periapical radiographs. So that's a huge lesion. I suspected a lesion, a huge lesion, and also maybe in the lateral. So you can tell there is a lot of not working treatments or not a lot of failed treatment. At this stage, who would consider taking CBCT? Anyone? Just 3 in the room. So obviously, I took CBCT, and you can see I just took some slices for different teeth. So you can see in the upper right 6, for example, missed canal, missed mesiobuccal, second mesiobuccal. This is a mesiobuccal root. This sagittal view, you can see the lesion on the mesial root. The 1-4 is not so bad. There is a small lesion. There is no symptoms from these 2 teeth. Moving on. It's not working. Just give me a minute. The slide is not moving. What's happening? Okay. Okay, so that's 1, 2 on the left side of the screen. Again, she's not complaining from that tooth. And then we have the 2-1, with a huge lesion, perforated buccal bone, cortical bone. You can tell, and if you move on further on the left side, there is also a lesion on the left side of the first premolar, which is root-filled and crowned. I'm not going to go through the treatment plan. I'm just going to go what happened. So we treated the left central incisor. The patient is not very motivated, disappeared. It took me 2 visits. Second visit after 2 weeks. That's the post-op, immediate post-op. Patient pain gone away, patient disappeared. 6 months later, I think she started to believe in dentistry. She presented requesting to do the full treatment plan, so re-treating all the teeth with lesions and having implant for the missed teeth and crowns and so on, the full treatment plan. So this is the post-op radiograph for the lateral. I started with that. You can see some extruded material. And then I did, this is a post-op for the upper right first premolar, and just after a cleaning and shaping for the first molar, then an obturation for the first molar. It's not a perfect periapical. Then the left side, I did a retreatment post-encore. Patient didn't want to do the crown until she's sure about everything. She had some temporary crowns, but not final crowns. And the patient then presented a few months later, a month or 2, complaining from a little bit of tenderness on the left side of that 2-5. I did an apical surgery with a little bit of retro filling or root end filling. That's immediate post-op. And I followed up the patient. Symptoms gone away a month later, because what I do 5 days after the surgery to suture removal, and then a month later for clinical symptoms, no pain. And then I saw the patient, a 1-year follow-up. I took a CBCT just to make sure that the lesions are gone, because she's still not a big believer of treatments or a dentistry. That's the pre-op on the right side. You see there's a B2 lesion is almost gone for the upper right 6. The same, this is a pre-op, this is a post-op, 1-year post-op. The same for the 1-4, is not so much going on for the 1-4. So there wasn't so much lesion to begin with, but I did it anyway because you see the pattern. She had so many lesions with so retreatment. I'm not going to leave anything behind. The same thing for the 1-2, which had a huge periapical lesion. You can see in the sagittal view, it's almost gone. It's not there. We know that large lesions heals slower than small lesions. This is the left side, which is the offending tooth that got her into our clinic at the beginning.
Dr. Mohammed, I'm sorry, we're about to finish the time. We are past 5 minutes now.
Okay, so it's almost 1 or 2 slides more.
You have 1 minute.
Okay, that's a pre-op. Then the post-op for the apical surgery that I did on the left side. That's 6 months follow-up for the surgery. And I'm done.
Wow.
For any questions?
Anyone have any question regarding the topic? Any different ideas, different opinion? Well,
Yes, the back.
Thank you. What's the material that you close with the apical after surgery? Most that you use?
For root end filling, you mean, or the retrofilling, right?
Yes.
Bioceramic materials. Yes, bioceramic putty.
You don't use MTA?
I used to use MTA, now switched to bioceramic, which is very similar.
You think? So you feel that bioceramic is better?
That's a very tough question. I don't think it's better in terms of healing, but it's in terms of manual handling is much easier. You don't have to mix it. It's easier. And although it's not related for apical surgeries, but it does not cause any discoloration for maybe another purposes. So it's a little bit better.
Thank you.
No problem. Any other questions? Okay.
So, thank you for the lecture. I have one question. So, what's the reason behind retreating 1-5, since like the patient was asymptomatic and there was no lesion in there?
That's a very good question. The reason is basically because I saw a pattern. She had a lot of treatment done many years ago. So and there was a little bit of a lesion, probably a lesion, maybe not. But I decided to do it just to make sure that, because she want to crown the tooth as well, and there was gonna be an implant in between the 4 and the 5. I think I have it somewhere. Yeah, there was gonna be an implant between them because it's a 1-4 and there is a 1-6 and there is an implant in between them. So I just want to eliminate any potential failure. So I just was prepared for apical surgery if it fails. Okay? Any more questions? Okay, thank you again.
thank you, Dr. Mohammed. Thank you. Thanks a lot. Now we're gonna welcome our next speaker in the row.
Test.
Our next topic is titled Surgery First versus Conventional Orthognathic Approach. Surgery First approach has been introduced as an alternative for conventional orthognathic approach in the treatment of patients with dentoskeletal deformities. So when do we decide between the conventional approach and the surgery first? Does surgery first reduce the overall treatment duration? I'm especially honored to present to you with our next doctor, Dr. Mohammed Kamal. Dr. Mohammed Kamal is a German and European board certified oral and maxillofacial surgeon, fellow of European Board of Maxillofacial and Head and Neck Surgery. Dr. Kamal is dually qualified in dentistry and medicine and licensed physician and dentist in Kuwait and Germany, and has been trained at several top-ranked international universities. He's currently working as an assistant professor of oral and maxillofacial surgery at Kuwait University Health Science Center, Department of Surgical Sciences. He's focusing on the correction of facial deformities and corrective jaw surgeries. Dr. Kamal is well published in several internationally renowned medical journals, reporting on various clinical and basic science research projects, and his work has been presented and published in several medical journals and international scientific meetings. Please welcome him.
Okay, thank you, Dr. Noor, for the kind introduction. My presentation is going to be quick, concise, and just going to touch upon the basic concepts of surgery first orthognathic surgery versus conventional orthognathic surgery. When you hear the term surgery first, what does that mean? We know that oral and maxillofacial surgery, in oral maxillofacial surgery, we deal with complex dentofacial deformities. And in order to correct those facial deformities, we need comprehensive approach and evaluating everything with the orthodontist and the general dentist. Then we have to come up with a big and well-documented treatment plan. We have to utilize the best medical technology that is available to us in order to establish a complete treatment plan for the patient. Now, this is a patient, for example. Patient has an obvious class 3 deformity. This deformity is not going to be corrected by orthodontic treatment alone, and the patient needs surgical intervention in order to reposition the jaw, and then we have a corrected facial profile. So if we look here, let's see. So if you look at the simulation there, we're advancing the maxilla, we're setting back the mandible, we're trying to adjust and correct the facial deformity by using the technological advances available. But still, there are other steps that we cannot predict in surgery. In our clinical scenario, we have to always plan for the orthodontic intervention. We can do surgery first, or we can do orthodontic treatment first. When we say conventional, conventional means orthodontic treatment first. So this is an actual result after surgery, and this patient has been done using conventional orthognathic surgery case. So the objectives for every orthognathic case is to improve the functional issues. I mean the bite, I mean the temporomandibular joint problems that are coexisting, and we have to improve the facial aesthetics overall. And nowadays, with the advent of medical technology, we can evaluate the soft tissue of the face in detail and evaluate every aspect of the face. So we can evaluate the symmetry, we can achieve and evaluate the facial proportions in detail, and from that we can do a comprehensive bite-related re-establishment of the occlusion, plus correction of the facial proportions. So given those two goals, we have two approaches: conventional orthognathic surgery, in which we have a patient coming in with a deformity, then the orthodontist goes ahead and does the orthodontic decompensation, that means the alignment, in preparation for the surgery. And then after a year or two, most cases, patients come in after several years of orthodontic treatment, because the first orthodontist tries in to solve everything without surgical intervention for 2-3 years, and then the orthodontist fails, and then the patient goes to another orthodontist who starts from the beginning. So usually the patients come in after 4 years of treatment at least. So conventional orthognathic, patient goes into orthodontic treatment, unknown period of orthodontic treatment until everything is aligned in a position that is suitable to conduct the surgical procedure in the third picture. And then after that, short period of orthodontic treatment after surgery, so that you reach the final result. So this is in terms of terminology. Advantages of conventional orthognathic surgery is that since we're doing orthodontic treatment before surgery, so we are spending a lot of time detailing the pre-surgical planning and focusing on meticulous orthodontic treatment. After a couple of years, when the patient is ready for surgery, then we do the surgery, everything has been planned before, and after that a short period of orthodontic treatment comes in, and the patient can move on after 2 to 3 to 4 years of combined treatment. It's been working well, but not always. Some patients, after a couple of years of orthodontic treatment, they will start coming in and presenting with problems. So this is the option that we've been talking about, and the next is the surgery first orthognathic surgery. In the past, this was a very difficult thing to predict, but now, again, with the advent of technology and the use of 3-dimensional CT scanners and software planning for VSPs, we are able to do better job with the prediction. So in this case, we say, okay, the patient comes in with the same deformity as in the first picture, as with the first case. Now, instead of doing 2 years of orthodontic treatment and then do the surgery, if the case has enough stability, let's do the surgical intervention first, do the surgery, and then the orthodontic treatment. Or what I do is I tell the orthodontist, start bonding the case, put the brackets, everything 1 week before surgery. Then I do surgery, and then 3 months after surgery, when everything is healed, we can continue with the orthodontic treatment until we reach the final results in 6 months. So the best thing, the advantages of this scenario is that we can get faster aesthetic improvement and immediate functional benefits after surgery, because whatever you did, you kind of decrease the level of the deformity. Although the occlusion is not perfect, but you didn't make the patient worse like in the first case. The first case in conventional surgery, you had to decompensate. When you decompensate, you make the patient look worse. But here, no, we didn't make the patient look worse. We brought everything in a better skeletal relationship. So we have immediate improvement in the functional outcome, and the most important thing is the reduced overall treatment time. So if you go ahead and compare our patients in both approaches, in traditional orthodontic surgery, you do orthodontic treatment before surgery for 1 year or 1 year and a half, and then you do the surgery, and then couple of months of treatment of orthodontic intervention, fine-tuning after surgery. If you do surgery first, then you eliminate the pre-surgical orthodontic treatment. You start the surgery and the orthodontic treatment simultaneously and continue the treatment, the orthodontic treatment after surgery. So we have something called rapid phenomena of the bone healing. So this bone, the orthodontic treatment is going to be faster. It's going to be faster than without surgery. So even instead of doing a year of post-surgical orthodontic therapy, you can do it in 6 months. So this case, we ended up doing conventional orthodontic surgery. So patient underwent 5 years of pre-surgical orthodontics. He went to 5 orthodontists. He came to me after 5 years of orthodontic therapy. His oral hygiene is not good. During this time, he had open mouth, open bite. So for the past 5 years, he's been suffering with an open bite, not able to chew on food, cannot close the mouth. The hygiene inside of his oral cavity has changed significantly because of that. He says he used to be better, but regardless, after 5 years of non-successful orthodontic therapy, it is understandable that some patients cannot keep up with the hygiene. And this is what he presented with. In this case, we went ahead, we did conventional orthodontic surgery because orthodontic therapy was done. And I did the planning, complete re-evaluation of the face, and trying to put everything in the correct position, advancing the maxilla, advancing the mandible, the chin, lower facial height. So complete planning. This is easy. I can do this in half an hour, do the surgery in 2 hours. For my job is the easiest part. It's just the 5 years that the patient went through over the past 5 years. This is the story that I'm discussing here. But in terms of surgery, it's easy. Can they come to the clinic? I do the planning in half an hour. Khalas, the surgery could be done in 2 hours. This is not the difficult part. So this case also complete the planning. You look at the nerve. I evaluate pretty much everything into the oral cavity and within the skeleton, and this could be done in a predictable way. But what do you think? This option, was it good for the patient? I feel that if the patient came initially to me and going through surgery first, orthodontic surgery, probably that would have been a better thing to do. If the patient initially presented to me before starting orthodontic therapy, and simultaneously I was able to decrease his open bite and at least make the relationship of the jaws closer to each other, then the orthodontist could do a better job finalizing the case. This is a before and after of the case after simulation. The case went well, but that prompted me to think more about cases like that, doing orthodontic surgery cases. So this patient came to me. He got accepted as a pilot at Kuwait Airways, starting to work after 60 days. ما عطوه chance. 60 days لازم تبدي دوام وسنتين ما تاخذ إجازة. So this is what he said. 2 years I'm not going to be able to take any vacation to do surgeries. My work starts as a pilot in 60 days. Within these 60 days, I want to finish orthodontic treatment and orthognathic surgery completely. This class 3 deformity is significant. Now you'll see inside the oral cavity, look at the oral cavity, it's significant class 3 deformity. So in this case, we went ahead and we did surgery first. So communicating with the orthodontist, Dr. Farid Rabahani here, we were able to discuss how we're going to plan it. And we went ahead, did complete planning as usual, following the surgery first protocol. So I went ahead, planned everything, and did the surgery simulation before and before after. So skeletal movement simulated, soft tissue movement completely simulated. Now I know from the beginning, before touching the patient, this is my plan for the surgery. Again, this is the easiest part. I take the patient to surgery and I do the orthognathic. Also takes a couple of hours and things are done from a surgical standpoint. That is immediate result after surgery. After 4 hours of intervention, still no orthodontic therapy done. And after that, he went back to the orthodontist, and the orthodontist can continue with Invisalign. And after 60 days, he's back to starting his work. So let's look at the 3D evaluation before and after. This is actual result. هاي مو simulation. اللي على اليسار حتى اللحية لو تلاحظون غير. Before 1 month after surgery. والتغيير الأزرق, blue means advancement. There is increase in volume. The lip, the upper lip went forward. The nose tip went forward. The orange part and the yellow part means volume decrease, reduction in volume. فصار عندنا reduction of the lower lip, improvement in the upper lip. And now we did great achievement to the patient that we changed the shape of the face or the overall look of the patient within a few days, and then the patient can continue with orthodontic therapy using Invisalign. So to summarize, advantages of surgery first versus conventional is that we can do great aesthetic improvement immediately after surgery, immediate functional benefit as well. If you have the relationship of the jaws closer to each other, we can have an immediate function as well. Overall treatment time is definitely reduced after surgery first orthognathic surgery. We're saving at least a year. Pre-surgical orthodontic therapy is reduced or eliminated altogether. Adjustments immediately post-operatively is possible. Patient will have a greater experience because of a quicker visible results. We need to do quality of life evaluation and patient-reported outcomes after these cases to have objective evaluation measures. طبعا time for consultation, post-surgical stability is the main concern, but if you use a proper dynamics, you will be able to have great results. So surgery first is not as dangerous as you think. Still, if you do proper planning with the advent of this technology and the availability of these devices that we have, we can achieve excellent results. This is all of my information. I'm available at any time. This is my personal phone number. You can call me at any time should you have any question, and thank you very much for listening. Questions?
Mike.
The questions. Maybe you do
You know? Any questions? Do you have a question or? Yeah, if anybody has a question.
Questions?
Actually, I have a question.
وفي سؤال عندها.
أمينة دكتورة أمينة.
Go ahead, ارفعي ايدك يلا.
Thank you, Doctor, for the lecture. My question is, comparing the final result of both technique, would the conventional way have a better aesthetic outcome?
No, the aesthetic outcome depends on how I planned my case. If I spend time evaluating every portion of the face accurately and I did accurate planning, then the outcome will be the same. The outcome is a function of my planning as a surgeon. If I do a bad job in planning, I'll do bad job in both. If I do a good job in planning, then I will do good job in both. So no, you're just taking the jaw and position it in a closer position for the orthodontist so that they can complete their job faster. And the results in terms of cosmetics definitely will be the same as the other one because you're not changing any soft tissue relationships other than what is done during surgery.
Okay, my second question is, we usually do the decompensation to allow maximum correction in the surgery. So without the decompensation, still can we achieve maximum
For the
correction?
difficult cases, such as difficult class 2 div 2s, this will be difficult. But for most of the cases, if you have class 1 malocclusions, if you have open bites, if you have a class 3, this case is possible. If you have big transverse discrepancy, it will be difficult. So not every case could be done as surgery first, but almost all, pretty much 90% of the cases could be done if you plan them accurately. And the decompensation, I don't tell any orthodontist to extract teeth, never. I never tell an orthodontist to extract teeth. This is something that we use in the US during residency in San Francisco. It was a conventional thing. Extraction, mandibular, orthognathic surgery. If patient has class 3, we set back the mandible, advance the maxilla. For the ones who came into my lecture in the morning, class 3 deformities, I advance the mandible. I don't set back the mandible. I advance the mandible. I never set back the mandible. If you set back the mandible, you have soft tissue sagging. This concept of decompensation, you can play around with it with a counterclockwise or clockwise rotation. When I move the maxilla, I can move the mandible and adjust it without the need for this extra decompensation. Just align every tooth in the correct position within the alveolar bone. وهذا اللي أنا أقوله حق الأورثو. Align everything in the correct inclination. Don't worry about me. ما عندي overbite, I will deal with it. You deal with correcting the angulation of the teeth in relation to the basal bone.
Okay, thank you.
Thank you. Any other questions? Noor?
Yes, doctor. I was going to ask you, are there any cases where surgery first is the only option?
Surgery first, it is never a requirement or the only available option. It's an option that is available in our armamentarium. But again, for every case, we have to assess the risks, benefits, alternative treatment options, and we weigh all treatment options. So basically, no, this is not the solution for all problems. It's a way to solve a problem that we face with other cases.
Yes.
Yeah.
Thank you so much, doctor.
Thank you.
Thank you so much, Dr. Mohammed. I have a question to the audience now, and we had a problem how we're going to select who we're going to answer. Dr. Mohammed, any ideas?
Yeah.
Any ideas of how to select the answer, or who's going to answer you?
So how they're going to ask it verbally?
Yeah, I'm going to ask verbally, yes. Just you select your
Select
from the audience.
person who chooses?
Yeah. Who want to participate? Who want to participate to answer a questions from Dr. Mohammed Kamal lecture? No, I want someone want to participate because it's going to challenge a little bit. Okay. Okay, I'm going to ask. Dr. Mohammed Kamal asked, what are two main advantages of the surgery first orthognathic surgery?
I said 3 points. عندنا 3 advantages. You can mention 2. اللي يبي يجاوب 2 advantages. شنو المين advantages؟ تفضل.
Quicker.
Reduce treatment time.
More aesthetic?
And what?
More aesthetic?
Aesthetic, immediate aesthetic improvement. Yes, correct.
Shukran.
Congratulations. Please, step forward. Go next. Now we're going to continue our next topic.
Okay, we'll proceed discussing the gray areas within the dental field by addressing periodontitis, periimplantitis. Periimplantitis is a destructive inflammatory disease of soft and hard tissue surrounding dental implants. Due to the large prevalence, accelerating pattern of progression, and evasive predisposing factors, periimplantitis represents one of the unresolved challenges of the contemporary implant dentistry. Is non-surgical management of periimplantitis effective in comparison with surgical management? Each operator has a choice of either managing a compromised implant that has a questionable prognosis or extracting the implant and starting from scratch. Our next speaker will illuminate and guide us through the dilemma. Dr. Abdulaziz Al-Jazzaf graduated from Virginia Commonwealth University in 2004. He continued his postgraduate studies at the University of Pittsburgh. He became a diplomat in periodontology in 2010 and currently works in both government and private clinics in Kuwait. He's elected as a board member in KDA and is the vice president of the current year. I'd like everyone to welcome him to the stage.
Okay, can you time me? Okay, fine. Okay. So how many of us know how to deal with implantitis or periimplantitis? Okay, how your approach? Remove the implant. That's a very solid opinion, honestly, and it's really cutting the way the treatment short, basically. The other opinion is to try to deal with it or try to hassle with it. How? So, people jump to grafting and they get failures, and they jump grafting again and they get failures, and they keep changing the product, the technique, and all of that. But the thing is, the patient is not ready to receive it yet. Even a new implant, he's not ready to receive it yet. So how we select clinical criteria aesthetic implant success? Basically, you need healthy periodontal tissue. You need optimal scallop form. You need healthy gingival color. You need symmetry. And you need optimal papilla form, and you need tissue stability. Focus on tissue stability. If you have a mobile tissue, you're not going to gain anything. If you have a mobile membrane, you're not going to gain anything. If you have a mobile bone, you're not going to gain anything. Example here, if you see the maxillary incisor, upper maxillary incisor. So this is a mean labial bone thickness 2 millimeter apical to the gingival margin of maxillary. A range is 0.83 when the tooth is out. That's the buccal plate range. So how you can save it? How can you? How to the asset? Better? Sorry. So what I was saying, when you remove the tooth or when you remove the central incisor, a thin buccal plate will remain. The mean distance of this buccal plate is 0.83, it's below 1 millimeter. If you try to save it, you need another bone graft membrane to stabilize it. Even that will not be stable because the buccal plate is super thin. That's why you always get 20-30% from your sucker preservation in the anterior zone. So what we are saying here, when you extract the tooth, you rely on the blood supply. Number one, you rely on the blood supply that's going to feed your graft or you're going to feed your socket. These coming from two plexuses. You have the periodontal ligament vascular plexus and you have periodontal vascular plexus. Periosteal vascular plexus, sorry. So you have two sources of blood. This source, the first source will be gone. The PDL will be gone with the plexus. You're going to rely on the periosteal. You want to make sure the periosteal is there. That's why when you do full thickness flap, you jeopardize the blood supply. That's why you do partial thickness flap. That's why you keep some periosteal there, so you can have your blood supply. Extraction socket, easy, you get a dry socket from there. But the blood supply itself is essential to get your bone back, to gain your socket back. A CT scan taken and from after 37 days for extraction, that's the thin line that I was telling you about on the left side. This is the thin line is gone after the time. Although you didn't do anything, you did socket preservation, maybe you put a color cone and suture exit, but at the end you're going to lose the socket. So how we can keep it there? Always there is a recession or there is a resorption 2 millimeters labial ball thickness of the cerebral in the long-term stability. So what we need is a 2 millimeter all around your implant, mesial, distal, buccal, lingual. You cannot rely on the buccal wall on the mesial and distal to say I'm gonna stable my implant or gonna add the bone graft material covered with membrane. This bone will not turn to your patient bone. This will stay the material you bought, even if you entered after 1 year after. Why is that? Because if you're imagining adding bone, you have a biotype to deal with, and you have a chances of recession, same chances that you got from the first tooth. So the series of recession goes that direction, type 1, 2, 3, 4. The best one is type 1, thick gingiva, thick bone. The worst one, which is very susceptible to recession, is a type 4 gingiva. Thin bone, thin gingiva. To reach your maximum is to get this reversed. So we need the type 4 to make it type 1 first. Then we can have an implant stable. Same concept here. Again, thick gingiva, thick bone. That's what we need, and you go to that direction. You want to reach, if you started with number 4, you have to reverse it. So what I'm saying here, socket preservation, GPR, and CTG is the essential procedures you need to keep your implant intact. Not always the bone need to be filled there. Socket preservation, again, a lot of studies proven that they maintain the socket and they maintain your height. Even if you put bios or you put any animal material, that non-resorbable material, this will hold, scaffold the place. But the regeneration is very high, that is strong enough to eat your bone away and you regenerate your own bone. But in a scenario that you're relying on a membrane to build up a wall, this is a chance of failure happened. Socket preservation, 180 days, bone stays. Dehiscence, you placed it, connective tissue. Do not place bone now. Connective tissue will work better. Why? Because the blood supply for the connective tissue regeneration is better. Sometimes you add a lot of bone here, do not add, and not adding any tissue replacement, you will end up with a thick bone, thin gingiva. This will go, this will recede, and this will resorb away. Again, you're on a stage of the second stage. You need the connective tissue, you need some tissue grafting. So you have connective tissue grafting at the day of the exposure or the second stage. And that way you gain more of stability of your implant in the long run. Interproximal bone loss always happen. 1.5 millimeter loss is always happening there. It's circumferential around it. It's like a pocket created. So you have to keep in mind every time you flush the bone, you flush the implant with the bone, they have 1 millimeter, 1.5 millimeter reduction happening anyways. So you count that. If you have the 2 millimeter, you have in mind that the 1.5 millimeter will go all around. You always have buccal, lingual, and mesodistal walls there. A very famous study was saying here is a bone to implant relationship in the aesthetic. Do not place them close to each other, do not place them very far from each other. Ideal distances is about 3 millimeters between the two implants. And why is that? Is to keep that middle bone intact. To keep this height intact, what keeps it, you give you the papilla support, or like a backup support. A very classic study too, that when you design the distance between the two teeth, the height from bone to the tip of the papilla is 5 millimeters. If it's more than that, you're gonna lose, you're gonna have a black triangle no matter what you do, no matter how much fillers. It's gonna rely on your, where is the platform will finish and where is your contact form will create it. So you count where is you flushed with the bone to the tip of your contact. This is where you're gonna get 6 millimeter. Full bony, full papillary fill. So again, in that study, we have the distances that they recommended, so you can have a full thickness or a full papillary fill. Tooth to tooth, the recommended proximity. If it's 1, we're gonna get 5. If you get implant to implant, you're gonna go 3 millimeter apart, so you get a 3.5 vertical tissue back. So how to treat it? To treat peri-implantitis based on the radio and clinical bone loss. Local bone loss around 1 implant, if it's local, or systematic, it's all around the mouth, or all implants around the mouth. So first, you need to evaluate if it's only 1 implant, then you have to treat it oral hygiene, focus on the plaque removal, then flap surgery, smoothing the implant threads to assure healing, and success steps. A lot of studies show that even the cement will erode your titanium, even the cement that's coming after your crowns. If it stays there for more than 2 weeks, it will erode your titanium. It will scratch it. It will cause plaque accumulation, although it's a fresh titanium. A lot of factors that affect your titanium is the way you handle the titanium itself. When you open the flap, you cleaned up very well. You try to smoothen up these threads. You need to smooth them as you do a route planning. You have to get them back to where the environment they need to be friendly. Any sharp edges will be accumulating food again. Any threads kept will be not filled, will be causing calculus again. So tissue grafting is more beneficial than more bone grafting in this scenario because I'm carving a lot of titanium. If it's generally, then we can go to Dr. Ali's technique, which is Dr. doing implant, graft, and removal. But there is a systemic factor. The failure didn't happen from oral hygiene only. I have a super clean oral hygiene patient, but they get failures. The reason unknown. What's happened? Why? I always had it. 10 years ago, I placed an implant. Didn't happen. Why now? What happened, doc? One fact in mind, the first attempt of bone grafting is your highest chance of success. So do not rush to that box. Wait. Prepare the site. Remember, your highest chance of success is your first attempt. Second attempt, you're doing a less. Third attempt, you do a less and less. Same thing with the implant placement. Your first chance is your highest chance. So do not attempt it unless you are ready for it. Remember, the goal is to reach type 1 peri-implant tissue before you place the implant. Replacement of the tooth is not the goal now, you need the stability of the tooth itself. Avoid overfilling of the graft, give some room to all components, give some room for the blood supply, for your bone and for your membrane, and connective tissue on top of it. So you can imagine how much elasticity of the graft you need to have to get this primary closure in. And always cover the bone graft with a membrane of ORCT, as we said. Flap closure is essential. If you leave it open, if you leave it on closure, if you leave it very, very loose, it will go. Everything you put, you will go again. The closure should be tension-free, watertight free. Watertight, when you skip a water, the water shouldn't pass. That is how tight you have to be. Not overlapped, you have to be edge to edge, tight. And suture types, of course, you need a threaded, single threaded is the best. Multi-threaded will cause, will accumulate more calculus and will cause it ugly after 1 week. 1 week, 2 months, 4 months, 6 months, follow the healing. Follow up with CBCTs, follow up your tissues, follow up any changes in the patient health. Now, this is my scenario when I start a patient. Imagine yourself, you do an implant every day for patients who doesn't care about payment. They do it for free. So every time you do it, okay, you fail, let's do it again. You fail again, let's do it again. And I keep hassling with this patient. I'm working in a place that everyone getting an implant, everyone getting the material, even the bone grafting. When receiving this much of cases, you receive variety of cases, every kind of cases. Now I need to stop this wave on me. I need to filter it. I need to give it why I'm getting failures. I should have 100% of success. So we did like a criteria of how to filter this pool of patients. So imagine all your patients who's coming, you're not going to negotiate a price. You're always going to keep implants until you're getting teeth fixed. Let's do this. Okay. So all these conditions is causing implant failure in the long run. But I did like a score sheet. If you're getting this score sheet of 5 and above, you're not taking an implant until you're taking the score down below 5. And every condition is a 3. So if you're talking about a smoker, less than 5 is 1, more than 5 is 3 points. So it's counting as additive points, and you go over it over there. In this scenario, I'm doing 2 things. I'm monitoring the patient health, I'm fixing his medical problems, and he will not receive this free implant until he's ready to have it. So you can see the orohagine, diabetic, osteoporosis, osteoarthritis, osteopetrosis, anticoagulant, liver, kidney, heart diseases. Bisphosphonate is my enemy. Systemic lupus, pemphigus, herpes zoster, Hep C, Hep B, HIV even. I don't mind, but it's a point on me. It's a high chance of failure, so you need to clear up all your list above so you can place it for an HIV patient. Cancer until the finished treatment, radio, and chemotherapy. In that total, I give him always 5, 6, 7. If he got it, quit. If he quit, okay, now we are below 5. Let's go, proceed. And that's it. Questions?
Yep, if anyone has any questions, please raise them now.
Hello. Yep.
Doctor, thank you for the lecture.
Do you have a question? Yeah?
Yes. It is 2 questions. My first question, there is one of the cases you said it is better to put connective or tissue graft better than grafting bone. Why we don't do both? Usually, I do both in the upper aesthetic zone. And the second question, what is the problem with the baby aspirin? It is for the fibrinolytic activity or what?
What's that again? Sorry. Last part?
What is the problem with the baby aspirin? Many patients are on baby aspirin all the time.
That's true. Baby aspirin is a blood thinner, okay? If you rely on the patient history from his words, baby aspirin is a 375 baby aspirin. You say it's small baby aspirin. So not always the patient saying baby aspirin, it's really baby aspirin. You need to make sure that it's not the 375 mg, it's the 75 or 80 mg. That's when we call it a baby aspirin. I put it precisely on that because a lot of people think, I'm just taking aspirin. Okay, but 375 is high. The bleeding will be a lot. And if you are decorticating this bone, you're going to have a flow of blood. Any more? You had another question, right?
Yes.
my first question, in the upper aesthetic zone, you said it is better to put soft tissue graft, better than adding bone. Why don't you
In the scenario I showed, because we have a thin bone, thin gingiva, thick bone, and on the anterior we have some threads exposed, right? If you try to pack this bone, you're not gonna have enough tissue to cover it. So you need to tissue graft first. And in that scenario, maybe you're not gonna need this couple of threads to cover with bone. The tissue graft, I would say, is very thick. It's a connective tissue graft. You take the underlying connective tissue graft, put it in the labia, stabilize it, close the overlap flap, you will gain a natural healing.
Thank you. Thank you very much.
One more?
Thank you. About the biphosphonate, the patients under biphosphonate IV or tablets, how do you decide to take the patient or to do implants, or do you do them?
I did, and some of them I regret. The level, again, I work in a place that I can follow up the patient reports. I can follow up his numbers. He cannot say anything different to what I'm seeing. I'm working in a hospital. So even if he said I'm controlling my blood sugar, I know he's not saying the truth. So in that scenario, the doctors prescribing the injection fast, and they take it like 2 or 3 years in the back. They don't even remember they took that injection 6 months after. But once that's in the body, your game gets reversed. And you need to work on reversing this medication. Either you convert it, try to avoid surgery as much as you can, extract with a flap and closure as soon as possible, and make sure that the patient doesn't go involved with the bisphosphonate, especially the IV ones. Once they got it, even a single injection, you will lose it.
So better not to have headaches.
It's not the headache, the reverse is taking a long time, and it's a lot of pain.
About the baby aspirin, well, I understand that they might bleed, but if we stop the baby aspirin 3 days before, or is it recommended?
No, it is recommended to keep the baby aspirin ongoing for a severe or just recent cases, or for recent surgeries done. So in that scenario, I tell them to keep the baby aspirin, keep taking it. I'm not going to take that risk. But again, the green light comes from his physician at the end. Do not take the attempt, even of that. Even if it's single implant, straightforward, believe me, a single void in the bone, you will make your nightmare.
Okay, thank you.
You're most welcome. Thank you very much.
Good evening, everyone. It's a pleasure for me to introduce our next topic of the night for the dental gray area, which is in fact an orthodontic topic comparing the efficacy and effectiveness of our conventional fixed appliance therapy with clear aligners. Because as we all know, our patients nowadays are more aesthetically demanding than they have ever been before. And with that being said, we are also fabricating more contemporary and aesthetic orthodontic appliances than ever having been done in previous years, especially as more adults are seeking orthodontic treatment. This is aided by advancements in material science, imaging, 3D printing, and CAD/CAM technology. With that being said, I'm very pleased to introduce Dr. Mohammed Qali, who obtained his DDS from Virginia Commonwealth University in 2015, and then finished the combined periodontic orthodontic program, as well as his master's degree from the University of Pennsylvania in 2021. He now serves as an esteemed faculty in the Faculty of Dentistry at Kuwait University, as well as the University of Pennsylvania and Temple University. I will now leave the floor for Dr. Mohammed. Thank you very much.
أحمد كده دقيقة.
Okay, hello everyone. Pleasure to be here. Thank you very much for spending your Thursday afternoon with us. I'm going to try to keep this as interesting as possible for Thursday afternoon. Yep. Can you hear me, everybody? Sounds on? Okay, perfect. All right. Thank you very much for the kind introduction. This is my current academic affiliation. I'm going to start talking about cases. From that, you are in your office. This patient shows up. Demanding their treatment. Yes, can you hear me now? Okay, perfect. You're at your office now. This patient shows up to your orthodontic office. You're going to be playing an orthodontist for the day. This patient comes in. She, as you can see from the ring on her finger, she's a college student, but not yet graduated, right? Because if they graduated, they will wear it on the right hand. Now on the left, that means she did not graduate college yet. She comes to you and she's like, Doc, I've seen recently some pictures. I think my bite is not normal. Can you do something for me? So when we see a case like this, we have to think about options, right? We know that this patient is clearly indicated for orthodontic treatment. But the question is, are we going to do fixed or removable? Team fixed, team aligners for this case. It's 50-50. Fixed? Okay. Who's going to use aligner in this case? One. Okay. So in this case, actually, we decided to do fixed therapy. There's going to be limitations of aligner therapy that we know. One of the limitations of aligner therapy is dentoalveolar expansion. This case needs clearly skeletal expansion. There is a limit of how much we can expand in this case. So what we did in this case, we actually did send this patient for SARPI. I do MARPIs, mini screw rapid expansion. However, the palate is so narrow that we cannot do a MARPI in this case. It's a clear indication for SARPI. We had to go through 3 different expanders. You have to warn your patient that during the treatment, it is going to be scary because you're going to have such a large diastema that's going to open up. Once that's happening, we have to clearly consolidate that space. Slowly but surely, things start looking better. And what looks so difficult is not so difficult anymore. So for that case now, that patient, we transferred her life. And the good news in this case that we're going to go talk about is the patient graduated college. We get to spend 2 years with this patient, so we get to witness that. Just the reason I mentioned college, this patient was non-syndromic, a very smart patient. She wanted something more in her life. This is an indication for fixed appliances. Whenever we have the limitation of each appliance, we have to know what are we using. Going on to my second patient, she is an Asian American patient. She comes in with a chief complaint. My lower lip is protruded. I don't like my crowding and lower lip. She does have history of periodontal disease. So that does tell me I cannot do a lot of IPR because we don't want to have any root proximity in this case. So when I have a case like this, the patient is highly aesthetically driven, as you guys can see. She says, I want to do aligner therapy only. Is there any way you can maybe help me with that case? What do you guys think? Who's going to do aligner only or fixed? Fixed, team aligner. Fixed, aligners through. We know the limitations of aligner therapy is what? The limitations of aligner therapy is derotation. So if we look at my case, we have almost 190-degree rotated lower right canine. So to derotate this canine, I'm talking about minimum 10 months of aligner treatment. I can finish that with fixed braces without touching the upper arch because the upper arch is simple. So what we did in this case, we actually went ahead and we did extraction. And please remember this. Anytime you are extracting a case in your adult patients, please remember to do ridge preservation because extraction in adult patients is not the same as 4x extraction in adolescents that have other teeth that are growing. Because if I did not ridge preserve this case, I would end up with a huge defect that would make it difficult to close the space. So for this case, what we did is we went ahead and derotated the tooth in 3 months. It was September, and in 3 months we are done. Now what we tell the patient, okay, you gave me 3 months with fixed, nobody knew you went through braces, now I'm gonna jump the case to aligners. So this is the hybrid modality. The hybrid modality means I'm gonna use the fixed to help me whenever I need to, and then go to aligner therapy to jump my cases. Moving on to the third case now that we talk about is, this is the same case. We can see how we clearly maintain the occlusion and we improved the patient's profile, where we addressed the chief complaint of that protruded lower lip. So moving on to this patient. This patient comes to me, he demands orthodontic therapy. He does not want to go through mini-screw assisted rapid expansion. We know that MARPI is a valid option for patients that are like in their 30s, 40s, we can use it. This patient says, okay, I want to align my teeth. However, I want to look aesthetically pleasing. Crossbite correction does not matter. Do you guys think it is an absolute necessity to correct posterior crossbite? Who thinks it's a necessity to correct posterior crossbite? Actually, evidence does not say that. There's clear evidence that people live with posterior crossbite. Normally, that's fine. The reason is you don't want to think about only dentoalveolar expansion and then create a periodontal problem. If you are only thinking about the teeth and forgetting the roots, you're going to create periodontal problems. This is a great case for aligner therapy for a couple of reasons. First is hygiene, of course. Second reason is we have a class 3 pattern with an anterior open bite. The strength of aligner is vertical control because we have that full occlusal surface of the posterior teeth that's going to be using as our vertical anchorage. That what will happen is, if I just put braces on these teeth without extraction, it's going to fly forward. So that's something to keep in mind. Then what we did in this case, we clearly decided, okay, what we're going to do is we're going to slowly but surely, as aligner therapy, we're going to use it to help correct the bite in the dimensions that we need. And then we went from an anterior open bite to closing the bite to intentionally keeping that posterior crossbite. However, if you want to leave posterior crossbite for the patient, you have to remember the buccal crown torque of the anterior teeth. I want you to remember that because what happens is if you control that torque of the teeth, you're going to have the best smile that the patient has when they are smiling. Another indication for clear aligner therapy is this is a fellow friend of mine. He is an oral surgery resident. And we guys know residency is difficult for a lot of people, but oral surgery in specific, he's like, I like you as a friend, but I want to see you as minimal as possible. So this is a case, if you think about fixed, you are not in a good position. So in this case, you want to think about aligner therapy because we can see the patients every 4 to 5 months. And now in the digital era, we can do the virtual appointments. Everything is fitting fine. We go ahead. This patient, we get ahead and corrected his smile. He saw me only 3 appointments. Consultations, delivery, and now here he is. He's almost ready for debond. Just something to keep in mind with you guys is whenever you see a midline discrepancy, think about the functional shift before ever considering doing any differential IPR, because once we corrected the functional shift, we have the midlines clearly on with aligner therapy. With that being said, I'm just going to finish our topic with something really important to think about is retention, is retainers. What retainers are more important? Let's just look clearly about the history of retainers. Nowadays, we look at people and think, did everything we invented was new? You know the concept of aligners was invented in 1971? That was the invisible retainer that came along in the 1990s where align technology came with the Invisalign patent. But it was somewhere there. I just have to look back in time to look at that. So always think about your cases, about are you going to do removable versus fixed. There is indication, contraindication for each. However, the key thing that I want you to remember from my lecture is there is not only one treatment. You have all these armamentarium in your box that you can choose per case. And as a doctor, you're not dictated by a tool. You are a doctor, those tools will help you to create this. And I want to finish it with one of my favorite quotes is, as you can see here, we go ahead. An investment in knowledge pays the best interest. And as you guys are all here today, spending your Thursday evening trying to seek some knowledge. I really commend you and thank you for being here.
Are there any questions from the audience?
Yes.
What's your opinion about delivering the aligners? Hello, thank you
Yes.
for the nice
Yes.
presentation. This is maybe a question outside the lecture.
Yes.
Now the aligners are being delivered directly to the patient,
Yes.
maybe in the United States, I don't know where.
Yes.
What is your opinion about that?
Definitely, and thank you for the great question. Direct aligners is definitely something I don't recommend, because what happens is we have to look at the patient periodontal status as well as the patient caries risk assessment. Once we have those clearly in the office, we can do it monitoring it. With us using aligners, they will have direct supervision instead of unsupervised treatment. So I don't recommend it at all. And actually, there's a lot of lawsuits against those companies now. If you look at their stock prices, they're like going down significantly. Yep.
Thank you.
Next patient. Next. Go ahead. Perfect.
Thank you, Doctor, for the excellent presentation. We're going to be moving on to our next topic, and it's about the various treatment options for peg-shaped laterals. Peg-shaped laterals are defined as microdontic under-contoured maxillary lateral incisors. Their eruption can often lead to a disruption to the natural harmony occurring in the patient's dentition. With various treatment options available, it can be difficult for inexperienced operators to decide between full crowns, veneers, or composite resins, especially when considering patient factors such as age, the health of the dentition, and the severity of the size discrepancy. I'm pleased to present the next speaker, Dr. Mohammed Sabti, who graduated from Kuwait University and proceeded to complete his postgraduate education from the University of Maryland School of Dentistry. He's a full-time faculty member at Kuwait University and is an assistant professor in the Department of General Dental Practice. Please give him a warm welcome.
Okay. Okay.
فتحت المايك؟
شغلة؟ مو شغال. السلام عليكم. Hello everyone. So my lecture will be even shorter lecture, inshallah. It's not going to be as interesting as Dr. Muhammad, but I'll try my best. So my topic will be mal-shaped lateral incisors, whether to go ahead with porcelain veneers the conventional way or doing composite veneers, okay? We're going to talk about each and the advantages and disadvantages of each. So whenever you get small lateral teeth, whether they are peg-shaped or just hypodontia, you have to make a decision whether you're going to go with the conventional porcelain veneers, which has its own challenges, or the composite veneers, which also has its own challenges. But we're going to be talking about each and the advantages and disadvantages. So basically, let's talk about porcelain first. With porcelain veneers, some cases need preps, okay? So prepping a tooth that's already smaller in size, has a large pulp, usually peg-shaped and smaller teeth have
a really large pulp. Okay, so prepping these teeth that are already small can have its negative effects. Okay, and porcelain also has superior strength and durability than resin. Do you really need that strength for a lateral incisor? When you're talking about a molar or a premolar, you do need the extra strength that comes from porcelain. But do you really need it for a lateral incisor that has very light or even no occlusion sometimes? Of course, porcelain is less sensitive to operative technique, okay? Unlike with resin veneers. The resin veneers, you need good isolation, you need to build it up layer by layer, so it takes just more time and effort. If multiple teeth are involved, indirect veneers can be placed in a much faster and easier way. And porcelain, of course, can last longer and be more aesthetic if you have a good lab technician. Always, whatever porcelain restoration you make, it always depends on the lab you're working with. If you have a good lab, you're going to have good margins, you're going to have good aesthetics, good translucency, and a good fit overall. Okay, so you're going to avoid a lot of problems. And only if you have a good lab to work with. Now we're going to be talking about the composites. Most clinical cases require minimal to no preparation. Okay, about 95% of my composite cases, I do not even touch the tooth. Etch, bond, and add to the tooth, especially if they're already smaller tooth. And minimal amount of material needed. Okay, you don't need to cover the whole tooth. If you have a small lateral, you can only add to the areas that you need to add. Okay, most of the cases, you do not need to cover the whole tooth, unlike with porcelain veneers. It can be done at an earlier age. For porcelain, you always need for the growth to complete before you can place a porcelain veneer or a porcelain crown. Okay, what with composites, you can always start it at an earlier age. As early as 14 or 15 years, you can place your composite veneers and the patient can be just more satisfied with the aesthetic and have more self-confidence. No finish nile is needed. With porcelain again, most of the cases they need a definitive finish line, so you do need a preparation, but with composites you can just blend the composite into the tooth that you have. Wherever you want to end the margin, you can end it, as long as you're using the right shade and good bonding. Easier shade matching. To me, matching a composite restoration to a tooth is much easier because the patient is there in front of you. You can mix and match the colors until you have a good shade. While with porcelain, you do have to communicate the shade with the lab, and it can be challenging sometimes, especially if you don't know how to take good shade measurements for the tooth itself. Okay. Again, you need a good lab to be able to give you a good shade for the tooth itself. Sometimes you tell the lab to give you an A1, and he gives you like an A2 or a B1. And you can change the shade if it's incorrect or if the patient bleaches their teeth. And a lot of my cases, 1 month after I place the restoration, the patient comes back, I have a wedding, I need to bleach my teeth, okay? Or someone told me my teeth are dark, I want to bleach my teeth. With porcelain, you're just going to have to remove the whole porcelain veneer, especially if it's only one tooth, and you're going to have to tell the patient to bleach before you remove the porcelain, and then remove the whole porcelain veneer, and you take a new impression and new shade selection. And also the shade is not usually stable with bleaching. Eventually the shade will come back to the original shade with time, unless you do frequent bleaching maintenance, okay? But with composite, you can always remove a thin layer, sandblast the old composite restoration, and etch and bond and add to the composite. So I can always easily change the shade of my existing composite veneer with a new shade on the spot, okay, without removing the whole composite restoration. And you can change the shape and size easily. Sometimes when the patient goes home and comes back, he says, like the tooth is a little bit wide, it's too long, and whatever, you can easily change that with composite and then repolish. With porcelain, it's a little bit more challenging. And you can add to adjacent teeth at the same time if needed. A lot of times when you have peg-shaped lateral incisors, they are usually accompanied by malformed like centrals, even if they look normal, but they usually, the line angles or the incisal edges look different from normal, okay? So sometimes, most of the cases, they need addition to the centrals and canines. So rather than having porcelain veneers on the whole 6 anteriors, just to fix the lateral, you can also just add a few composite restorations on the adjacent teeth in addition to the veneer that you have, okay? So the disadvantages, I mentioned most of them. Porcelain is a lot more expensive, especially if you're in private practice. It's more expensive than composite veneers, and especially if you need to do more than one tooth just to fix this one peg-shaped lateral, the patient needs to pay a lot sometimes, especially in private. So shade matching also can be challenged, as I mentioned before. You need to wait until growth is complete. You cannot do it for teenagers, especially after ortho. A lot of my patients come to me after early orthodontics, like 14, 15-year-olds. They have a peg-shaped lateral or a very tiny lateral, and they want to fix it. With porcelain, you're going to have to tell them you have to wait until you're 19, 20 years old, okay? But with composites, you can do it right away so that the patient can be a lot more comfortable. You need to prep the teeth. In some of the teeth, you need to prep. Need to make accurate final impressions. There's always the impression part of the veneer that you need to do. You need to have a second appointment for the delivery, and during the second appointment, if the shade is not correct, you've just added another appointment by retaking the impression and making a new veneer, especially if you don't have an in-house lab that can add some staining to your porcelain veneers, okay? With composite, the disadvantage is it can be time-consuming, okay? So you do need more time than prepping and making a final impression for the composite itself, because it does take time to layer the composite. It's more technique sensitive. You do need to know what you're doing, and you do need the skill to do that, especially without having any overhangs or anything that can harm the patient more than being useful, okay? And shade selection also. Staining, if it's not polished very well, or if you do the wrong technique. A lot of people just, like for example, one example is wetting the instrument with the bonding agent before you apply, so that the instrument doesn't stick to the composite. You can do that, but you cannot do that with any bonding agent. Like an 8th generation bonding agent, you're not supposed to wet your instrument with an 8th generation bonding agent. It has to be a pure bond, like a 4th generation. And a lot of people do that with an 8th generation. This will cause staining on the surface of your composite with time, okay? So these small points here and there can have a negative effect on your composite if you don't follow them. Fracture, if you have parafunctional habits and patients with heavy bites and during lateral excursion, if you don't fix your restoration so that they are clear during lateral excursions and protrusion, you can have fractures, whether it's composite or porcelain. And loss of retention. Again, if you don't bond it really well, or if you have moisture contamination, you can fracture your composite. And staining, again, if you don't do it correctly, or the bonding is not correct, or if you don't polish it really well, you can have staining, especially if you skip steps during the polishing. There is a whole process of polishing. If you skip steps during the polishing process, you're going to leave scratches on the surface of your composite. That's why you need to polish from coarse to medium to fine while you are polishing, okay? And most composite restoration need to be polished more frequently than porcelain. Given all that, I still think that I always prefer to do composite in the beginning, because you can always switch from composite to porcelain in the future. Once you prep the tooth for porcelain, you cannot go back, okay? So I always do composite veneers first. If for some reason the patient is not comfortable, it fractures, or the patient is not happy with it, I can always switch back to porcelain veneers, but you cannot do the opposite. So I'm going to show you a few cases and how I treated them. For preparation, I always take photos and do a wax-up. And from the wax-up, I create my putty impression, which I can use for mock-ups to show the patient, and for a lingual guide or the putty matrix, and then I do my layering technique. I'm not going to talk about the technique because it's going to take too long, but I'm going to show you a few cases, okay? So this is a patient who came to me after ortho. She's 15, so I cannot really give her any porcelain veneers or anything. She has to wait a few years. So I just did some composite restorations. You can see the emergence profile from the gingiva. It's clean and it's polished, and you do not really need to cover the whole tooth. As you can see here, this is the tooth of the patient. The composite goes around. You don't really need to cover the whole tooth. And you can always, if you use a translucent composite, even if the patient bleaches, the composite will get lighter because you are bleaching the surface of the tooth itself, and the tooth under the composite will be bleached. So the composite will kind of change the shade while you are bleaching, okay? So if you do not cover the whole tooth, you can get away with bleaching 1 or 1.5 shades lighter, okay? Unless you want to bleach too much, then you need to replace or change the color of the composite itself. This is an adult patient. Also, he mentioned to me that he does not want to prep his teeth. He does not want to touch, because the tooth is tilted a little bit mesial. So if you were going to do a porcelain veneer, you would need to prep a little bit of the mesial incisal area of the tooth, okay? So I went ahead and did just a composite veneer. And I've been following him up for about 4 years now, and he's still happy with his restoration. This is a patient also after ortho. Sorry, this wasn't after ortho, but the patient needed a composite restoration. Now, because of the size of the space, you would think that you can do it with only adding to the lateral, okay? But actually, if you just add to the lateral, compared to the other lateral, this will be too wide, okay? That's why I needed to add to both the lateral and the canine. Again, with porcelain, you need to prep either both teeth or do the whole 6 anteriors to be able to match the shade, okay? And I'd rather just place some composite restorations and fix the shape and the shade of the tooth without even touching the tooth. Just etch, bond, and add to the lateral and the canine at the same time. In the same visit, one visit he comes to me with the upper picture, and the same visit he leaves with his composite restorations. Again, after ortho, very tiny teeth, and the tooth on the patient's left, you can see it's very small. And you cannot only restore these 2 teeth. You do need to add to the centrals and sometimes to the canines, okay? Because of the slope on the distal of the centrals and the embrasure between the 2 centrals, you do need to add to the centrals. So if you are going to do this with porcelain, you're going to have to do at least the 4 anteriors. So again, just composite restorations. You can change the shape of the centrals and change the shape of the laterals significantly without prepping anything, and just by etching and bonding. And again, you can change the color anytime by just removing a small layer and just changing the color, okay? This patient also came to me after ortho. She had a small lateral on one side, the other side was just normal. Again, if I wanted to add just to the lateral, there will be just a large embrasure between the central and the lateral because of the curvature of the distal part of the central incisor, okay? So I had to add a little bit to the central and fix the shape of the lateral incisor just with composite restorations. And you can see how you can control the shade so that it can be exactly the same as the patient's teeth, and add to the distal of the central without even being able to notice it. And the last patient, also 15-year-old female patient. She was very worried that she has to stay like this after ortho. This is just after orthodontic treatment, okay? Even after ortho, she did not like her smile, and we couldn't do any porcelain restorations for her because she's too young for it. And also, she had some gingival overgrowth after ortho, okay? So we did some gingivectomy, and we added some composites to the laterals and the canines, okay? Because of the slope of the canines, she was going to end up with really large embrasures between the canine and the lateral. That's why we can just add to as many teeth as we want without prepping anything, okay? With composite, it's nice that you can do as many teeth as you want and still be very conservative, okay? Thank you. If you have any questions. Oh, أسئلة. Anyone? I have 2 questions here.
Thank you, doctor, for the lecture.
You're welcome.
You are going with layering technique, or you are going for single shaped in case of big shaped lateral?
No, I always layer it.
Always layer.
Yes.
There is a space for layering in such cases. I see some cases it's very little space to make layering in it.
Can you show the presentation? Like this case, for example? Yes. You can always layer, you can always add staining. Even if you don't have enough space to add layers for the translucency, you can always add stains to mimic the incisal translucency.
But
okay?
I can't get that shade with mono shade.
It's very difficult.
It's very difficult.
Yes. You can, only if you're only adding 1 to 2 millimeters to the edges around the tooth. But you'll always show the original translucency of the tooth. So if the translucency, if you have a short tooth and it already has translucency, and you add just 1 shade, you're always going to see the old translucency and the new translucency that you add. So you're going to have a very long translucent edge on the incisal edge. So I always add an opaque layer on the old translucency of the tooth itself, and then I layer the new incisal edge that I place. If I don't have enough thickness for the layering, I add stains to get the translucency in the edge.
Thank you.
Sure. Any other questions? Yeah.
What porcelain do you recommend? Which
Usually, for aesthetic cases, feldspathic porcelain is the most aesthetic, but patients who need just a little bit stronger porcelain, I would use Emax, lithium disilicates. Yeah. But for incisal edges and patients who already have incisal translucencies on the edges of the other teeth, usually feldspathic is a lot more aesthetic and easier to get this nice translucent edges. But all these cases were composites, the one I presented, yeah.
Thank you, Dr. Muhammad.
You're welcome.
Thank you.
Sure.
Now we have a question for the audience from the doctor's lecture. I'll say the question, then we'll have volunteers, so get ready. What would you need to do before bonding to an already existing composite restoration? Let's go. Go ahead. Sure. Let's go to the left. Yeah. More straight. Okay, left. To the left. First one.
I should sandblast first and then bonding.
That's correct. Okay, I think you get a prize, so clap for her.
That's okay, I know. I'm just preparing. You want to introduce first?
Oh, okay, it's working. All right. Thank you very much, Dr. Mohammed Sebti. I'm very pleased to be now introducing our final topic of the night for the gray area in dentistry. This time we're going to be presenting a prosthodontic topic. As we all know from yesterday's implant symposium, implants have absolutely revolutionized the practice of our profession in the past 20 years. But within this very specific niche in the practice of dentistry, we still have some variability in the options that we can provide for our patients. A prime example of this is the choice of cement-retained versus screw-retained implant crowns, which each provide their own set of advantages and disadvantages. We all know that cement-retained crowns are more aesthetic. Of course, there's no access hole, so no disruption in the occluding surface. And screw-retained implants provide us with the luxury of retrievability and less biologic issues due to the absence of cement. They're also usually less expensive and hence preferred. For this topic, I'm very pleased to be introducing Dr. Jabir Akbar, who obtained his DDS in 1999 from the University of Missouri, Kansas City, and completed his residency in 2003 and master's in biology from the same university. He is an esteemed faculty member at the Faculty of Dentistry, Kuwait University, and is also the Vice Dean for Clinical Affairs. Sorry, okay. So without further ado, I now leave the floor for Dr. Jabir.
Thank you, Miriam. And I think you could have presented my presentation with the introduction that you presented. All right, good evening, everybody. And I'll promise I'll make it short and concise so you can leave and enjoy your early weekend or late weekend. All right, so we'll be talking, before we get into the topics, just as an be optimistic with all what's going on in life right now. This is our faculty. The building on, I cannot use the mouse. That's okay. The middle building on the left side is the Faculty of Dentistry. That's where the lectures and the labs. This is our clinical building, which is, if you've been to KDA, it's exactly, we're sharing the same parking lot, so we're across from it. And unfortunately, where is Muhammad? The gym is killing us with the parking space. Now, future-wise, hopefully, in Shidadiya, this is an overview of the Faculty of Dentistry that we'll be looking at. Hopefully, by next year, they will have the tender for building construction of the buildings. This is a north view. All the way in the lower corner is the entrance for the clinic. Over here, the parking lot for the patient will be in front of it. This is the courtyard. The building is in a U shape, so in the middle, it's a courtyard. All these glasses is the clinics of the students. That we'll be looking over the courtyard. And this is the south view of the buildings that looks at what we call the oasis, which is between the faculty. Hopefully, the plan is within 5 years, this will be ready and we'll move there. Let's just hope, and things change in Kuwait where we can be there. All right, so let's go over basic knowledge information. When we talk about cement retained, we're basically talking about the fixture being placed, and then we have an abutment that is screwed on or screwed in over the implant itself, and then we have a crown that basically we use cement to cement it. In the screw retained, we only have two pieces. You have the implant fixture itself, and then you have the crown built with the abutments will be screwed in over the implant. Just basic knowledge. Now, we'll talk about advantage, disadvantage of each one, then we'll hit on the main topics, which is the factors that can help you decide whether to do cement retained or screw retained. Now, when we talk about cement retained, one of the main advantage is the improved aesthetic. And basically, it's because there is no screw hole, so it will look much better anteriorly and on the maxillary arch mainly. And the mandibular, a lot of people don't mind because it's not showing much. It's another advantage of cement retain that it's easy to correct the angulations of an implant, which it's hard to do it with the screw retained. With the cement retain using UCLA abutments, you can fix a lot of malalignment, severe malalignment in the placement of the implant, especially if the surgeon did not use nowadays technology. With current technology, we should not ever get that poor angulation. But anyway, simplicity in placement, whenever you're working with the cement retain, is much easier clinical-wise than screw retain. Screw retain needs more precision. It takes a longer time. You need to screw it in, check occlusion, remove it, especially if you're doing a lot of adjustment in the occlusion. You have to remove it, do most of the adjustment outside, re-screw it. So it takes time with the screw retain. The cement retain is much easier. You're just treating it like a crown over a natural tooth, so it saves time. And it that's what a lot of textbook says, that's why I put it in red, reduced risk of screw complications. Recent study have shown that, I disagree with this, but it's because in a lot of the classic textbook, but recent study have shown that even with a cement retain, because still we have a screw that is screwing the abutment to the implant, there are problems that is happening same percent or same rate as what's happening with the screw retain. So this statement is iffy. You need to update yourself with the literature. Now, disadvantage of cement retain is number one, which is the main one, is difficult retrievability. With the cement retain, a lot of people faces hard time challenges to remove it. Being single is the easiest one to remove. Still, a lot of people face challenges with removing a single. The more implant you have, the harder it will be to remove it. So this is one of the main disadvantages of it. Hygiene challenges with mainly the reservoir of the cement. Studies have shown that people or dentists tend to leave cement behind. No matter how meticulous they are, still there are a little bit of cement. And that cement, excess cement that gets left over, increases with larger prosthesis or more implant because of the pontics that you have in the middle that will be hard to clean. A lot of those pontics, they will not be hygiene, especially if they're replacing soft tissue with the prosthesis and using pink porcelain or large pontics. A lot of those will be hard to clean. So there is a hygiene challenge with the cement retain. Potential for subgingival, we hit already on that. That's where the problem comes, and that's where Dr. Abdulaziz, Dr. Muhammad Ghuli will hate the prosthodontist because of this, because that's the main reason for peri-implantitis around implant if they leave those cements. Limited repairability because it's hard to remove it. If there is any fracture or any issues, most of the time the restoration will get destroyed, and most of the time you have to make a new one. Opposite to the screw retain. Now, when you go over the screw retain, the main advantage that people love it is retrievability. You can always retrieve that crown from the implant. Basically, go through the screw hole and unscrew it and remove it, whether it's 1, 2, or even a full arch restoration. So that's the big advantage of the screw retain. Enhanced hygiene because of the ability to remove it. Periodically, you can remove even a full arch, have your hygienist go through it, clean it, do all kind of work on it. And also, the design usually in the lab will be much easier to design it in a hygienic way than with a cement retain. Simplifying repair, we hit on that. Because of the ability to retrieve it, it's easier to repair it. So you can take it out, send it to the lab, fix whatever in it, and come back and screw it in. Last but not least, passive fit. Just like in the cement retain, we talked about the screw loosening. Here also passive fit. Now the main thing they talk about with the screw retain is because you need to have it passively fitting, that's an advantage. Unfortunately, to get that passivity with a screw retained implant, single one, it's a little bit easy with a single crown, but once you go and you add multiple implants, that's where getting the passive fits over multiple implants is an issue. And you always have to do extra steps, and still it's questionable. So the passive fits with the screw retain, yes, ideally you have to have it a passive fit with multiple implants. But again, studies have shown that actually the cement retain are more given. So you can actually have a passive fit much better with the cement retain and easier to achieve than with the screw retain. There is another issue that they looked at in the literature is that if the restoration were not passive, will I get a bone resorption? The amount of stress that that active cementation or retention mechanism of a screw retained over the implant have shown does not harm the bone. The bone will tolerate those stresses that are made. So way back, it used to be thought that if it's not passively fit, it's going to cause bone resorption around the implants. That's not anymore. Clinical studies, randomized clinical studies have shown that that's the opposite, and we'll talk about it in just a second. Disadvantages of screw retain, aesthetically limited because of the screw hole. So anywhere in the mouth where that screw hole can be shown, that will be a disadvantage, mainly anterior. Especially if you cannot, if the angulation of the implant doesn't allow you to do a screw retain, it's not palatally positioned, and posterior maxillary. There is a tendency of patients that they don't like that maxillary arch and the posterior to be shown. They don't mind the mandible, but they do mind the maxillary for a screw hole to show. Another disadvantage is limited angulation correction. You can, with a screw retain, fix the angulation or adjust the angulation up to 30-degree malalignment, but not more than 30-degree. Anything more, you have to go with the option of cement retain. So that's really a good criteria to use, and we'll talk about it in just a second, but that's really one of the main criteria that I think nowadays can help you distinguish whether you go screw retain or cement retain. Increased chair time because of that precision in the trial and the fitting and the adjustment that you need sometimes to do in the restoration. It takes a longer time than the cement retain, but it's still within the normal. Once you get past the learning curve, you should be fine with it. Potential for screw loosening, we talked about that with the abutment of the cement retain. It's more, that's what classically been talking about, that screw loosening that can happen with screw retain. Also this one with the preloading and pre-torquing the screw, it should overcome that problem. Several studies over the past 10 years have shown that. So if you pre-torque your screw when you screw it in, similar to the abutment, the loosening has reduced a lot. Now, how should I decide? The best way to decide is what I found in this article by Gomez and his colleagues, factors affecting the decision to use cement or screw retained fixed implant supportive prosthesis. What they did, basically, it's a critical review. They did it over 2 stages. The first stage, they wanted to identify the factors from the literature. So the first stage, they only looked at meta-analysis, systematic reviews, RCTs only, and they came up with the factors. Then they went and did a second stage where they included lab studies, finite elements, and case scenarios, and verified those initial factors into those articles. And they came up with 8 factors. Number 1 was aesthetic outcome as a factor to decide whether you go with screw or cement retain. Number 2 is the retention. And here, retention, aesthetic outcome is very clear. Retention, we're talking about the interclusal space between the implant and the opposing. How much space you have here, how much you have retention factor. If you go back to basic preparation, the amount of wall length that you need, 4 millimeter, and then all that, that's what it's been talking about here in retention factor. Biological risk, and we'll talk about that biological risk. We already talked about it, the excess cements that get left over, the stress of loose screws that can cause to the fistula and the periodontium, that also a factor. Then another factor is passive fit, fracture strength, occlusal area, restorability, and complications. They came up with those 8. when they looked at the literature, they basically called the first 3 determining factors. Those are the ones that you can use to clearly distinguish. If you use one of them, you can clearly distinguish between, okay, this case I'm going to go with screw retain or cement retain. Retention, I don't have enough space. I'm going with a screw retain. Easy, direct. It's not confusing, it's straightforward. That's why they called it determining factors. The other 5, they called it conditioning factors. Depends on the case. Depends on the clinician experience, what he prefers, the condition of the patients, how often you're going to repair. So that's why they called it conditioning factor. They summarized it, excuse me. They summarized it in this table, looking at determined factors, and the first column here, and the color here is the screw retain, cemented retain. The middles is the situation as far as where is the restoration. So when you look at aesthetic, if the implant was palatally emerged, you can do a screw retain easily. If the implant is corrigible, which means you can correct it, the angulation is not more than 30 degrees, then still screw is a possibility. But if it is more buccally oriented or vestibularly emerged, then that color means it's a high risk or it's not indicated. With aesthetic-wise, with the cementation technique, you can always do in the anterior region. Posterior, because of that 88% acceptance, because it's mainly in the maxilla and the mandible, there are a few patients where we said that they don't like the screw hole to show on the posterior maxilla. That's why the percent is low. But with the cement retain, you can always do cement in the posterior. Now, retention, I already mentioned that. If you have minimum space of 4 millimeter, then you need to go interclusal space, then you need to go with the screw retain. You don't have space for the cement retain. If you have more than 6, then you can always go with the cement retain. Anything above 6 is okay. Now, when you look at biological risk, gingival margin. Now, with screw retain, there is really no risk. Basically, what we're talking about here, number 1 is the location of the implant, how deep or shallow is the implant. You can always do, there is very low risk in doing screw retain. When you come to the cement, that's where it's critical. Because of the idea of always there will be some left residual cement there, anything, they always recommend that either your margins of the abutments are aquagingiva or slightly subgingival, no more than 1 millimeter. Anything beyond 1 millimeter, you cannot clean all the excess cement 100%, and you will leave some behind. That's why it's you have to avoid cementation technique or mechanism if the implant is so deep and you cannot, with the abutment, you cannot raise your margin. A lot of cases you can overcome this by using zirconia abutments, ceramic abutments, where you can easily, aesthetic-wise, if you raise the margin higher, aquagingival or 1 millimeter subgingival, it will not harm. So you can play a little bit with the material, the abutments that you have. Excess cement, again, there is no issue with the excess cement with the screw retain. Again, the studies that they reviewed, they found that that's why the single crown is green. That means the risk is low. They found that with single crown still, because you do have almost access 360 degree, the risk is with doing it as cementation mechanism is okay. It's very low. But once you start adding the more implants, short span FPD, longer span FPD, full arch, that's where really it's a high risk, because most definitely you're going to leave excess cement behind, and you worry about perio and peri-implantitis and the whole 9 yards. So those were the main factor. If you look at the other conditioning factors, the 5, I'll hit quickly on them. Passive fit with a screw retain with a single crown, it's easy to achieve, so it's a low risk. It's good to consider it with a screw retain, but the more you go with higher number of implants, that's where it's become, the difficulty increases, where it's really, if you can go with the cementation technique is better. You can see with the cementation technique, as far as passive fit, it's easily achieved with a single crown. With the short or long span FPD, yes, with the full arch, it's medium. but depends how many implants. If you're really going with ideal implants, you can do your restoration segmental rather than doing it a full arch. So it's always with the passive fits, it's more toward the cementation mechanism than screw retention. For the fracture strength, basically because of the screw hole that you have, that is affecting the strength of the ceramic. So that 3 millimeter screw hole, there are cases in the molar where it's 4. There are cases with the wide implanting can go up to 5 millimeter diameter. That gap is affecting the strength of the ceramic that can lead to chipping of the porcelain. So that's what we're talking about here. You get chipping, so with the screw, because the screw hole is weakening the ceramic, that's where it's a high risk. You experience, studies have shown that they are experiencing, in their review, experiencing more chipping with the screw retention, especially the full arch. You will see more chipping there. With the cementation, it's much higher strength because you don't really have any screw holes, so the ceramic is higher. Chipping is there, not related to the strength of the ceramic, more to the function, parafunctional habit that the patient might have. Other type of fractures, basically of the screw or anything, there is no difference between the two. As we mentioned, the screw, there is always the issue of the screw in both cases. Occlusal area, now this one, it's still hypothetical. Because you have the screw hole, and we've been taught in residency program by all the prosthodontists, by all the restorative doctors, don't load the screw hole. So that 3 millimeter to 5 millimeter space is being reduced from your occlusal table, so your chewing or your function is less. But really, there hasn't been any randomized studies, clinical trials that looked at the efficiency of mastication between a screw retained and cement retained. So really, they couldn't find anything in the literature that support that anecdotal statement that we always heard about it. The last two is complications. We have mechanical and biological. Mechanical is more with the screw retention because of the screw tightening and the load on the screw. And the chipping. It's less with the single crown and the cementation, but it's more similar to the screw retain with the short span FPD or the full arch. Biologically, it's much less with the screw retain. It's more with the cementation mechanism because of the excess cement. So you take that in consideration, the location of the implant. Retrievability, it's easily retrieved with the screw. With the cementation, I found personal, this is my personal experience, single crown, if you're using a temporary cement as your final, your permanent cementation for the restoration over the abutments, it's easier to retrieve. Yes, a lot of people hate because there is a higher chance that it might come off, and they hate to tell the patient that. Now, if you inform the patient ahead of time, you tell them about that, expect it, it's always, they will accept it. If you don't and it falls, that's where they really get upset. That's one factor. Another factor is you can use permanent cement, polycarboxylate. You can use zinc phosphate with a little bit of petroleum gel. Add a little bit in the mixture, around 1/5 of the mixture, make it with that Vaseline or petroleum gel, and use that permanent cementation. It gives you a higher strength than the temporary cement and lesser strength with that. Then there are also tools that you can use to remove and retrieve the crown. You have so the issue of retrieving you as a dentist is really not the issue. It's always the worry that it might fall out with the patient while they're functioning. Otherwise, with you as a dentist, there are certain pliers that you can use. There is like a chewing gum that you ask the patient to bite on, and it can easily retrieve the crown from the implant. So for single, you can easily retrieve it with the cementation technique. The problem comes, or the risk is higher, or it's more difficult with the FPD or the full arch. That's where it's really hard to remove it without damaging the restoration. And I think that was the last. Right? Thank you. Any question? Sorry.
Any questions?
Yep. كم دقيقة كان؟ ما طيب ليش ما خليتي؟ وأنا حاطة عشان أسمع. All right.
Talking about the cementation, you talk about the cementation of a single crown with temporary cementation.
Yes.
And what about a full arch?
Well, the same thing. With the cementation, well, the full arch is actually more indicated to use the temporary cement because it's...
Is it indicated to cement it always with a temporary cementation?
Yeah, the issue is this. It's always indicated. They recommend that so you can at least retrieve it intact. The problem is because of that fear that it might fall out while the patient is functioning, that's where some dentists will go with a more permanent cement, even a plain polycarboxylate or a plain zinc oxide. It's hard to retrieve it. So that's the tendency. They don't want to take the risk to tell the patient that might fall. I don't understand it, but just like whenever you deliver anything ceramic, you have to tell the patient that it might chip. It's not like your natural tooth. Even nuts, cracking nuts with your front teeth, with the veneers, they might chip. You need to be very transparent. It won't be a problem. But there is a lot of clinics or dentists who hate telling this, so they go ahead and use permanent cementation.
Yeah. Do you agree that sometimes we are obliged to do the hybrid, both like cemented, screw retained, and cemented retained for a full bridge, let's say?
I didn't get your question.
If you are doing a full arch in
Okay.
the posterior area, we use the screw retain, and in the front, because of the angulation, we are obliged to use a cemented retained.
So the same prosthesis, you're cementing and?
Cemented in the front, and some
So it's
teeth are
segmental.
screw
Okay.
retained, and some are cemented retained.
Okay, when we're talking about full arch here, we're talking about one piece restoration. Is that what you're talking about?
Yes.
And in one piece, you're doing both?
Yes.
I tend not to do that to simplify my design. I know there are cases like that.
I
but
mean, in the back, in the posterior, I do the screw retained. In the front, because I cannot do screw retained, I do cemented retained.
So what benefit you're really taking from doing that design?
Because if the case depends on the case in the anterior.
So why don't you do the whole thing cement retained?
Yeah, no, because I do the screw retained in the back. In the front, it is cemented with temporary cementation. So when I want to retrieve it, it's always easy. I unscrew the back and then I tap the front. So
But you know all your loads will be concentrated in the posterior, not the anterior implants. You will be overloading. Mechanically, you will be overloading your posterior implants in that design.
But if this is my question.
See, that's the problem with that design. Mechanically, it's really you're taking a risk of overloading the posterior implants.
Yeah, but my teeth are loading on the margins of the abutments in the front.
Yeah, but you have the cement layer that has a give to. The cement layer is acting as a cushioning that will not transmit the load to the implant as the screwing of the posterior implants. That's a direct. If you look at the studies with the finite element studies, and you see the amount of stress that gets transferred with the screw retained versus the cement retained, it's always higher with the screw retained. Now you're adding that long span and the cement interior.
Well, I do this because usually I like always
because
to
of the
retrieve
angulation.
my. Then I have one more question about the passivity of the screw. When we screw and it is okay, not 100% passive fit, it doesn't affect the bone. But doesn't it make stress on the screws themselves and they might break?
It does not affect the bone, but what they looked at or what they found from the review, the critical review that I showed, is it's putting stress on the ceramic. They found higher cases where the ceramic is chipping or fracturing, especially with the full arch, long FPD, but not the short FPD. They found more porcelain chipping with the long FPDs and the full arch when the implants is not passively fitting with the screw mechanism.
Not on the screw itself.
Not the screw. They did not mention anything about the screw.
Okay, thank you very
Sure,
much.
you're welcome. Any other question? Go ahead.
Screw retained abutment.
Well,
and there is a variation between system and other in having this problem.
Okay, I'll start from the second half. Is there a variation between different implants? Again, you're asking my experience. I'm basically using two systems most of my life, so I really cannot answer this because I haven't used other system. I'm mainly either Straumann or Nobel Biocare. So literature-wise, I haven't found the system-wise really affecting lately. Way back in the design of the screws, yes, but not lately. In the past 10 years, I haven't read any issues that different system had an issue. Now, with the screw issue, the main thing is you torque it to the proper torque as a passive fit. If there was any active fits, you might get screw loosening, and you might get the chipping of the porcelain. And you pre-torque it, which means rather than you torque it to 30 or 35 Newton based on the implant, what they recommend, you go slightly higher. That's what the pre-torque they're talking about. Usually you get a loosening. When that happens with the pre-torque, you're really back to what's ideally recommended by the implant. They found that doing that pre-torque will reduce the chances of screw loosening. Okay. Any other question? Thank you, Doctor. All right.
Thank you very much, Dr. Jabit, for the presentation. We now have one last question for the audience, and again, whoever answers correctly does get a prize. Okay, so it goes as follows. When considering biologic risk factors, which retention mechanism has low risk? Okay, guy in the glasses. Yep, you. Yep. Sorry, the gentleman in the glasses.
They all wear glasses.
The student at my university.
Well, thank you so much. I think, in my opinion, it's the screw retained. I think that's the safest.
Well, that is the correct answer according to the literature. Thank you very much. You win.
Thank you so much.
Well, thank you all. Thank you, Dr. Jaber, Dr. Mohammed Kamal, Dr. Mohammed Al-Faqam, Dr. Mohammed Sabti, and Dr. Ali Qali. Please, Dr. Mohammed Dashti, welcome on the stage. And we're going to start. Dr. Mariam.
دكتور محمد الفقم تفضل. دكتور عبد العزيز الجساف. دكتور محمد كمال. دكتور محمد قلي. دكتور محمد السبتي. دكتور جابر أكبر.
I want to thank our senior dental students for their great effort tonight. You were amazing, chairpersons and negotiator. Please, hands up. And tomorrow morning, do you guys have anything? Do you have any commitments? No? Yes? Afternoon, maybe? Anyways, you have eligible to have a free workshop with us. So you just select any workshops from the provided coming ones, okay? Welcome. So this is it for tonight. I'll see you tomorrow morning.